Good day, everyone. So now we will be discussing about pancreatic hormones and diabetes. So during digestion, your pancreas makes pancreatic juices called the enzymes. These enzymes break down sugars, fats, and starches. So your pancreas also helps your digestive system by making hormones. That's why we're going to talk about the pancreatic hormones and the disease or condition associated with this kind of hormone. So we all know that we have these kinds of pancreatic hormones. First, we have insulin, glucagon, and the gastrin and amylin. So let's focus on the insulin. This kind of hormone is made of cells of the pancreas known as beta cells. So how does insulin affect liver? Insulin stimulates the liver to store glucose in the form of glycogen, a large fraction of glucose absorbed from small intestine to immediately taken up by hepatocytes, which converts it into the storage polymer glycogen. Insulin has several effects in the liver, which stimulates the glycogen synthesis. We have the insulin that also has a major effect of or in the muscle and adipose tissue. We have the carbohydrate metabolism. First, it increases the rate of glucose transport across the cell membrane. It increases also the rate of glycolysis by increasing the hexokinase enzyme and 6-phosphokinase activity. It stimulates the rate of glycogen synthesis and decreases the rate of glycogen breakdown. Second, we have the lipid metabolism. So it functions by decreases the rate of lipolysis in adipose tissue and hence lowers the plasma fatty acid level. It stimulates fatty acid and triacylglycerol synthesis in the tissue. It also increases the uptake of triglycerides from the blood into the adipose tissue and muscles. And then it decreases the rate of fatty acid with the oxidation process in muscle and liver. So let's go down to the type of diabetes. We all know that diabetes is a chronic disease that occurs when the pancreas is no longer able to make insulin or the body cannot really make good use of insulin as it produces. So types of diabetes, we have the first one, the type 1 diabetes. This can develop at any age, but of course most frequently in children and adolescents. So when you have type 1 diabetes, your body produces very little or no insulin at all, which means that you need daily insulin injections to maintain blood glucose levels under control. The second one, we have T2DM, or what we call the type 2 diabetes mellitus. It is more common in adults and or geriatrics and accounts for around 90% of all diabetes cases in the world. When you have type 2 diabetes, your body does not make good use of insulin that it produces. So the cornerstone of type 2 diabetes treatment is healthy lifestyle, including increased physical activity and a healthy diet. However, over time, most people with type 2 diabetes will require oral drugs and or insulin injection to keep their blood glucose levels under control. The last one, we have GDM, or what we call gestational diabetes. This is a type of diabetes that consists of high blood glucose during pregnancy or in pregnant women. And this is associated with the complications to both mother and child. So GDM usually disappears after pregnancy, but women affected and their children are increased the risk of developing diabetes in the later life. So how are we going to diagnose diabetes? Or let us talk about the criteria in diagnosing the diabetes for non-pregnant women first. So we have the three ways to diagnose. It is available as we have oral glucose tolerance test, the OGTT, that is more sensitive and modestly more specific than fasting plasma glucose, or what we call the FPJ. Diagnose that diabetes is poorly reproducible and rarely performed in the practice. Because of the ease of use, the acceptability to patients and lower cost, the FPJ is preferred for the test screening and diagnostic test. It should be It should be noted the vast majority of people who meet diagnostic criteria of diabetes by OGTT but not by FPG will have an AC1 value of less than 7.0%. So both of these categories are risk factors for future diabetes and the CVD or cardiovascular disease. In the recent studies, both of these tests have shown that modest weight loss and regular physical activity can reduce the rate of progression of IGT to type 2 diabetes. So drug therapy or metformin after both we have orlistat and triglycerin are widely available. They have been shown to be effective in reducing progression to diabetes in single trials. So, though generally not as effective as the intensive lifestyle intravenous. Another criteria we have symptoms of diabetes and casual plasma glucose that is greater or less or equal to 200 milligram per dl that is equivalent to 11.1 millimole per liter. So casual is defined as any of the time day without regard to time since last meal. So the classic symptoms of diabetes include polyuria, polydipsia, and unexplained or unexpected weight loss. Another one, we have the SPJ that is greater than 126 or equal to 126 milligram per dl with the equivalent rate of 7 millimole per liter. And it is defined as fasting as no caloric intake for at least 8 hours. So another one we have for OGTT that is 2-RPG greater or equal to 200 milligram per dl, and at the same equivalent, this test should be performed as described by the World Health Organization using a glucose load containing equivalent of 75 gram anhydrous glucose dissolved in the water. Another test for asymptomatic individuals with diabetes condition. Testing for diabetes, we have to consider that from the age of 45 and above, particularly those with BMI that is greater than 25 or equal to 25 kilogram per meter squared, and is normal should be repeated at 3-year intervals. So we also have to consider the younger age that is carried out or more frequently individuals who are overweight with that kind of BMI range. And we have the additional risk factors are habitually inactive, first degree relative with diabetes, are members of high-risk ethnic populations such as the nationalities, the African American, the Indian Native American, and so on and so forth. We have delivered a baby weighing greater than 9 pounds or have been diagnosed with GBM in the early stage. So we also have hypertensive with greater than or equal to 140 over 90 mmHg. Another one we have HDL cholesterol level of less than 35 or equal to 35 milligram per dl. With that, it's 0.90 millimole per liter. As recorded, that triglyceride level is high with greater than 250 milligram per dl. And also they have to include the PCOL state on previous testing of IGT or IFG. So they also have other clinical conditions associated with insulin resistance, such as PCOS again, or acanthosis nigricans, and a history of vascular disease. So let us talk about the different types of insulin and their mechanism of action or mode of action. We have insulin preparation. Insulin preparation is dispensed as regular R and micropropamine hagidorn, the MPH formulation. First one, we have short-acting insulin preparation. This is a regular human insulin or from human human being that is excreted from the pancreas of a human body. And the two rapidly acting insulin analogs, these are clear solutions at neutral pH. The insulin molecules exist as dimers that assemble into hexamers in the presence of two zinc ions. So the hexamers here are further stabilized by phenolic compounds such as a phenol and metaxazole. The mutation engineered into the rapidly acting insulin analogs are designed to disrupt the stabilizing intermolecular interactions of dimers and hexamers, leading to more rapid absorption into the circulation after subcutaneous injection. We have, as follows, we have regular insulin. It is also a short-acting one with a soluble crystalline zinc insulin whose hypoglycemic effects appears within 30 minutes after subcutaneous injection. It peaks at about 2 hours and lasts for 5 to 7 hours when usual quantities with the 5 to 15 units are being administered. So intravenous infusions of regular insulin are particularly useful in the treatment for diabetic ketoacidosis and during the perioperative management of insulin requiring diabetes. So let's proceed. We also have rapidly acting insulin analogs. We have the insulin Lespro with the brand name of Yomalog. It is an insulin analog type in which the proline at position B28 is reversed by the lysine at B29 position. The second one, we have insulin Asport with the brand name of Novolog, a single substitution of proline by the aspartic acid of position of B28. The last one, we have insulin glulisine, a brand name of Apedra, that differs from human insulin in that the amino acid asparagine at position B29 is replaced by the lysine and the lysine in position B29 by glutamic acid. Note that these rapidly acting insulin analogs, when injected subcutaneously, these three analogs quickly dissociate into monomers and are absorbed very rapidly, reaching peak serum values in as little as 1 hour. The amino acid changes in these analogs do not interfere with their binding to insulin receptor. So the circulating half-life or the immunogenicity were all as identical to those of human regular insulin. The next one, we have long-acting insulin preparation. So we have protamine hagidorn or the isoprene insulin. It is an intermediate acting insulin whose absorption or mechanism of action and onset of action are delayed by combining appropriate and protamine so that neither is present in an uncomplex form of isoprene. So the MPH insulin has an onset approximately with 2 to 5 hours and duration of 4 to 12 hours. It is usually mixed up with regular Lispro, Asport, or glulisine insulin and given 2 to 4 times daily for insulin replacement. We have insulin glargine, a soluble and peakless, having a broad plasma concentration statue, a long-term or a long-acting insulin analog with the attachment of two arginine in the structure molecules to the B chain carboxyl constituent terminal and substitution of a glycine for asparagine at the A12 or A21 position created an analog that is soluble in an acidic solution but participates or precipitates in the body pH after subcutaneous injection. So this insulin has a low onset of action at 1 to 1.5 hours and achieves the maximum effect after 4 to 6 hours. The maximum activity or action of this kind of insulin is maintained for 11 to 24 hours or longer. Another one, we have insulin detimir. This insulin is terminal threonine that is dropped from the B30 position and myristic acid, a carbon-14 fatty acid chain in structure, is attached to the B29 lysine amino acid. affinity of insulin dipyramide is 4 to 5-fold lower than that of human soluble insulin. So this is a liver insulin looks like. And the duration of action of this insulin is about 17 hours at therapeutically relevant doses. The types of insulin works by the rate of or concentration of action and their duration of time through glucose infusion rate in milligram per kilogram per minute and the time by the use of R.
So, good day. This is Sarah's Earth Dixie for slide 20 to slide 33. So, insulin degludet. In this insulin analog, the threonine at position B30 has been removed and the lysine at position B29 is conjugated to hexadecanoic acid via a gamma L-glutamyl spacer. So, the half-life of this insulin is 25 hours. Its onset of action is 30 to 19 minutes and its duration of action is more than 42 hours. So the mixtures of insulins, so intermediate acting NPH in insulins required several hours to reach adequate therapeutic levels. So in use with patients with diabetes, usually requires supplements of rapid or short acting insulin before meals. For convenience, these are often mixed together in the same syringe before injection. The regular insulin or rapid acting insulin analog is withdrawn first, then the NPH insulin, and then injected immediately. Insulin delivery system. So these are the types. So insulin syringe and needles eliminate the need for carrying insulin vials and syringe. So insulin pens are disposable plastic syringe with needles attached are available in 1 ml or 100 units, 0.5 ml or 50 units, and 0.3 ml or 30 unit size. So the low dose is 0.5 are popular because many patients with diabetes do not take more than 30 units of insulin. So we have continuous subcutaneous insulin infusion devices or CSII insulin pumps are external open loop pumps for insulin delivery. The device of a user programmable pump that delivers individualized basal and bolus insulin replacement doses based based on glucose self-monitoring results. The inhaled insulin is a dry powder formulation of recombinant regular insulin. A technosphere insulin, Afrasac, is now approved for use in the adult with diabetes. It consists of 2 to 2.5 micrometers crystals of the excipient formyldicapiperazine, a large surface area for absorption of proteins like insulin. The pharmacokinetic study shows that the peak levels are reached in 12 to 15 minutes and decline to baseline in 3 hours, significantly faster in onset and shorter in duration than subcutaneous insulin. Medication for type 2 diabetes, we have sulfonylureas. The mode of action is increased insulin release from the pancreas. They bind to a 140 kDa high affinity sulfonylurea receptor that is associated with beta cell inward rectifier ATP sensitive potassium channel, and also they are metabolized by the liver and with the exception of acetohexamine. The metabolites are either weakly active or inactive. The metabolites are excreted by the kidney, and in the case of second generation sulfonylureas, partly excreted in the bile. The first generation sulfonylureas. Tolbutamide is well absorbed but rapidly metabolized in the liver. Its duration of effect is relatively short, 6 to 10 hours, with an elimination of half-life of 4 to 5 hours. And it's best administered in divided doses, like 5 milligrams before each meal. Its short half-life and inactivation by the liver. Chlorophomanide has a half-life of 32 hours and is slowly metabolized in the liver to the product that retain some biologic activity. Approximately 20 to 30% is excreted and changed in the urine. The adverse effect includes a hyperemic flush after alcohol ingestion patient and hypotonia due to its effect on vasopressin secretion and action. Tolazamide is comparable to chlorophromide in potency but has a shorter duration of action, more slowly absorbed than the other sulfonylureas, and its effect on the blood glucose does not appear for several hours. Half-life is about 7 hours. Tolzomide is metabolized to several compounds that retain hypoglycemic effects. Acetohexamide is no longer available in the United States, but has half-life is only about 1 hour, but it's more active metabolite. Thus, the duration of action is 8 to 24 hours.